Okay, topic we're all excited about, butt pain. It comes in many shapes and sizes. So this is a case me and Tiffany had not too long ago. You can all read that chief complaint. So it said, I was wearing cotton panties, and you know, when you get a wedgie, I have pain in my butt. And the objective triage note says, able to sit in chair without difficulties. But really history, like anything else, is super important. There are a couple of key questions that can usually tell you what the diagnosis is straight off the bat without even doing an exam. You want to know whether it's acute or chronic. You want to know whether they're having pain with bowel movements. And you want to know if they can localize the pain to one side. I'm not going to talk about all the causes, just the main causes we see in the ED, and a couple of key points. So in the ED, I think we have a tendency to be a little lazy, or when we don't know what's going on, we just call it hemorrhoids and shrug our shoulders and give them some steroid cream or whatever else. But the truth is, it's probably not hemorrhoids. Hemorrhoids don't cause pain. With a few notable exceptions. They present as bloody bowel movements, blood-coated bowel movements, itching, and it should be noted that the itching isn't actually the hemorrhoids, it's generally the poor hygiene that's associated with the hemorrhoids. So the only hemorrhoids that cause pain are external thrombosed hemorrhoids, which we see in the first two pictures, and internal hemorrhoids that are prolapsed. So thrombosed hemorrhoids are pretty easy to diagnose. They're right on the side. They're pea-sized. They're hard. They can be bluish or purplish in color. And we should actually be managing these in the ED ourselves. I've yet to see anyone do this, but all the literature says that if they come in within 72 hours of pain, that we're supposed to excise them. So previously, people in the ED used to do an incision, which is just a straight vertical line and take it out, but that's been shown to not be effective. So we're supposed to do an excision, which you can see demonstrated here. It's inject with Lido and then use scissors and sort of cut an ellipse around it and actually evacuate the whole clot. The other... Who does? Did it work? I guess the... So we'll move on. So the other time hemorrhoids can cause pain is what's called a hemorrhoidal crisis. So these are essentially grade 4 internal hemorrhoids that are unable to be reduced back into the rectum. So they're currently infarcting, and you can think of them as you would think of a strangulated hernia. In the literature, there are actually two ways to manage them, both with sort of similar outcomes. I think today people tend to take them to the OR for surgery, but if you wait and do nothing, they'll auto-infarct and the problem will essentially take care of itself. So I think this is a much more common cause of butt pain that we tend to miss, anal fissures. So they're a tear in the skin of the anal canal. The presentation will usually be clear by the history. They report searing pain during bowel movements that then slowly resolves and tapers off. And they end up becoming constipated because they sort of have fear of stooling. They can't be palpated, and if you're thinking this and you see this, you do not need to do a rectal exam because that will only cause incredible amount of pain and won't help your diagnosis at all. As I said, these can't be palpated. The way to look for them is you actually take your fingers and spread the verge as best you can and look for them. They're almost always located posterior midline, and usually they can be found next to skin tags. So these are managed conservatively first, so that's diet modification, stool softeners, and then you can either give them nitroglycerin ointment, which is not very well tolerated, or topical diltiazem. Chronic ones should actually be referred to surgery. And this will be relevant a little bit later. So it's thought that the chronic ones exist because of increased pressure in the anal canal. And so they actually get a distal internal sphincterotomy, where they make a cut about here throughout the whole length of the internal sphincter. And these people do not lose continence. And then I think this is the most common one that we sometimes struggle with in the ED, anorectal abscesses. So this process, it says here there are 4 types, and in the literature there are 4 types, but I think it's a little misleading. It's more like there are 3 types, because intersphincteric is where all these abscesses start. Essentially, there are anal glands here that secrete into the canal here, and these get backed up, causing an infection to come out here. And then from this point, this is the intersphincteric groove. This right here is the internal sphincter, and this right here is the external sphincter. The infection can go one of 3 ways. So most commonly it comes down, and this diagram's actually a little bit wrong because it has the perianal abscess here. It's actually more where I put the circle where they present. Or it can go out into the ischioanal or ischiorectal space, or it can go up into the supralevator space. So generally, these get managed either by us or by surgery, and so the question is who deals with them, and it basically comes down to a superficial versus deep. So most commonly we see these, which is the superficial perianal abscess. I think for some reason we punt these a lot to surgery, and I'm not really sure why, especially in if we're working in the community. You're not going to get a surgeon to come in for this in the middle of the night. Basically, juniors come up to me when I've had a few of these and ask, like, do we need to image them because we don't know where it goes or what it connects with? And the truth is, it doesn't matter. It still needs to be drained. It's an abscess. The treatment for that is drainage. And these are generally pretty simple, and unless the patient is toxic and there's something more significant going on, you don't need imaging. All right.
Do you need the rectal first to feel the fluctuations inside?
I don't think so, not with these. If it's simple there, you can try and see if there's more distally. Like the endovascular or endocavitary. So anyway, I often hear people saying get surgery because we don't want to cause incontinence and we're not going near the verge. But the truth is you actually have a lot of space here, especially if you see, or if you feel fluctuants and you see pus. You probably have like an inch here and another inch to play with up here. And the surgeons, as I mentioned before, who do the sphincterotomies don't cause incontinence, and they cut through the entire muscle. So really, if you're just doing a lancing or sticking a little 15 or an 11 blade in here and get pus and don't cut like a madman, there's sort of no way you can do damage. The correct way to do it, or the proper way to do it, is a radial incision, so like spokes on a bike wheel, starting from inside, going out. The other abscesses, the ischiorectal, often they can only be diagnosed on digital rectal. There'll be exquisite tenderness when you go deep. I don't know whether we're good enough to appreciate the fullness that happens here. Same with the supralevator. The supralevator and the ischiorectal need to be managed in the OR surgically. However, if they're taking a long time to go to the OR, you can actually lance these ischiorectal abscesses, and doing so, it's thought that the cause of incontinence from these abscesses is more due to the infection and the continued pressure. So you're more likely to do damage by waiting and doing nothing than sticking a needle in or sticking a knife in and providing some relief.
So when you see this, what triggers you to be concerned about deeper abscess and to pursue more imaging?
So I think white count can help you a lot, fever can help you a lot, but really it's if you have a good story for this pain and you do a rectal, and they're exquisitely tender and in pain and you sort of don't have findings. I think those are the only people I would image. And
If you see a clear bulge, that you know where to go, but sometimes you don't.
Right.
You can look for the point of maximum tenderness, but there may not be obvious exactly where you're going to put your blade.
are you talking about for the perianal or the ischiorectal or both?
Perianal is more superficial.
Right.
That you can see, but it's more deep ones where you may do a rectal exam and feel something, but it's hard to actually find it.
Right. And there's a lot of space, like they can go to the OR, I was talking earlier, and they can pull out like hundreds of milliliters of pus from the ischiorectal abscesses. Any other questions? That's it.